interventional research to really talk about in a single keynote. I wanted to bring everybody up to speed with the developments in the field of amyloid, but there's so much else going on in the field that really when the program developers offered the opportunity to do an additional breakout session, I really thought, this would be a great opportunity to be a little more comprehensive and really not just to look at where we've been and how we've made it as far as we've made it with anti-amyloid therapies, but what else is on the horizon. So as always, disclosures in general, and our learning objectives really very similar to those this morning, looking at, and today we'll look at not just drug targets, but also data that's come out from one of the major studies of exercise just this past year. The majority of what I'm going to present today is really information and data for active studies, especially those that have come out in the last year. And so we'll start off the top. And let me just refresh everybody to know I only have one monitor on my computer. I guess the university couldn't afford to buy me two. So I can't see the chat. I don't know if you guys are able to unmute. If you can, feel free to unmute and say and interrupt if there are questions. Otherwise, we should be done in time to review through and go back over any questions that any of you may have and put in the chat. So anyway, taking off from where we left at the keynote, we know that targeting amyloid only slows Alzheimer's by about 30%, and we know that that's not enough. We also know, as we talked about a little bit previously, that if we're only treating the amyloid, and most cases of mild cognitive impairment and dementia are mixed disease states, then maybe we've got to be looking at other targets. Pure AD is really only 27 to 40% of the pathology found in most of these cases at autopsy. And so there's a lot going on. Up to 73% of mild AD is contributed to by other pathologies. So we'll walk through kind of where the field is currently. And I'm going to start with one study that indeed does look at amyloid as well. I promise the rest of what we're going to talk about today has little to do with amyloid. We do know that the amyloid antibodies are going to require people to have an MRI scan of the brain. We know that not everybody's going to be eligible for those. And so other approaches for targeting amyloid are very, very important. And this is a study that's ongoing. Currently, it's looking at, again, this pyroglutamate amyloid, this development, and how amyloid is transformed into pyroglutamate is through an enzyme that we'll just call QC for this point. And once you've made pyroglutamate A beta, that really drives the aggregation and toxicity of the protein. So there have been a medicine that's designed to decrease this QC activity so you can't make bad amyloid anymore. Very, very important. And so this is trial data that came out and was published in 2018. It's led to the current study funded by the National Institutes on Health. 120 people were randomized, 60 to placebo, 60 to the intervention. And then they looked at potential effects. And they looked in a variety of different ways. So the neuropsych testing, clinical, what they call the one-back testing, which is basically showing people cards and then asking them, what was the card that I showed you before this card, to see if you could pull that back. we did see that people's timing and accuracy on the one-back test was improved. The effect was quite small in these 60 folks, but there was a huge effect in suppressing QC activity. Also, a reduction in other spinal fluid markers that have to do with degeneration. Improvement in electrical brain activity by EEG, and the connection of the brain markedly improved in areas hit early on with Alzheimer's disease. So this provided great evidence that blocking this QC activity may be another way where we don't have to give people infusions. They can take a pill at home and potentially have these same benefits, especially if they're not eligible for engaging with a monoclonal antibody. So I promised we wouldn't just talk about drugs, and so we are going to talk about exercise, because this is also a year where we've heard for the first time about the benefits of exercise. Now, we've known this from the past, that people who are high exercisers are at lower risk for dementia. Those that lead sedentary lifestyles are at much higher risk for dementia. And we know that this may be related to growing new nerve cells in the brain, especially in the memory areas of the brain. And so a lot of work has gone into, let's really take a look at the positive effects of exercise. And so the EXERT study, again, funded by the National Institutes of Health, was an exercise trial for patients with mild cognitive impairment to try to prevent them from going on and developing Alzheimer's disease. So we had two groups in the study, people with MCI, and this was done in conjunction with the YWCA, and the people were randomized to either aerobic exercises, heavy duty workouts that get your breathing and your heart rate up, or simple stretching and breathing exercises. They were treated for 2 years. And at the end of the day, when we looked at the data just over the last year, we found that, by golly, there was no difference between the two groups. We thought that you really needed to get breathing heavy and your heart rate up for exercise to have a benefit, but we didn't see any benefit at all. So we went back and we looked at another study that didn't have any kind of exercise in it, ADNI, and compared the patients. And what we were able to see is that these folks with mild cognitive impairment that do not exercise, they get worse on their memory and thinking testing over time. Those are the pink violin plot that you see elevated over the blue. Those that exercise are able to maintain and not get worse over time. So this is some evidence that suggests that it's not really the type of exercise that you do. And if you have patients who, have congestive heart failure or COPD and can't get out there and huff and puff and run 10 miles, they don't have to. They can stretch and breathe. Now, what was very important, and I'm not showing here in this in this single figure, was that the exercise was done in a social atmosphere with a trainer and the like. And people exercised in that social environment for part of the time, and then kicked over into an independent exercise program. And what we could see was that there was a clear effect of the social engagement. People are going to do better with any kind of exercise. Again, you don't have to kill yourself, but really combining it, if you want the maximal benefit, combining it with social engagement is absolutely critical. Now, we also know, in addition to the amyloid in the brain and cardiovascular health, that neurofibrillary tangles are a big issue. And the pictures of brain sections at the bottom are of a mouse model that basically demonstrated in 2012 that once these tangles start, they take on a life of their own, moving from nerve cell to nerve cell. They no longer care whether there's amyloid in the brain or not. And we can look at these tangles with PET scans. Again, you can see an Alzheimer patient on the far right up top. What's you see in red and yellow is tangles building up in the brain. So what can we do about those tangles? Well, we've known for well over a decade that if we take the mouse models, what we call Alzheimer's disease, where they grow tangles, and treat them with antibodies against tau, we can prevent the majority of Alzheimer's disease. So this really has sparked the field. And, you know, as of this year, 282 clinical trials targeting tau on the clinicaltrials.gov website, 71 currently recruiting. And yet we've seen some early phase 2 studies that have not shown benefit. They can affect tau, but we're not seeing an overall clinical benefit despite our enthusiasm to not just address amyloid, but to address tau and tangles as well. So this is a study that came out over the last year. One of these antibody trials against tau called the Tauriel study. And these are the results. They looked at an antibody against tau, and they looked at the CDR, the clinical dementia rating in panel A. And what they found was no difference. Everybody got worse, no matter whether they received the tau antibody or not. Different from what we saw with the anti-amyloid therapy. With the ADAS-Cog13, we start to see maybe some spreading from the groups, but no clear dose response curve for the medicines. So these are moving forward currently, but it's unclear what that path forward is for tau studies. Chances are, from what we've seen so far, it is not going to be antibody infusions. We're going to have to find another way to reduce tau and tangles. So now we know that age is the #1 risk factor for Alzheimer's disease. So how about anti-aging medicines? So that's wonderful. So we'd all like to stay younger. I know I'm a little bit gray and starting to bald a little bit. Not happy with that at all. But what causes us to age? And so we've learned about these parts of our chromosomes called telomeres. They're these little orange caps on our chromosomes. And when we're born, our telomeres are really, really long, 15,000 base pairs. And as we move to adolescence, they get smaller, and adulthood smaller. And as we get older, they get smaller and smaller. Eventually preventing the chromosomes from fully functioning the way that they should to power health and growth in the body. This is an intrinsic mechanism, part of the aging process. And so people have long toyed with, well, what if we could prevent that? We should be able to prevent aging. And age, again, #1 risk factor for dementia, as you can see in the graph. We may need to do something about aging. So another vaccine has been developed. Not a vaccine targeting amyloid. This is a vaccine that targets telomere effects. It protects nerve cells from toxic compounds, from death, from damaging oxidative stress. It protects them from amyloid toxicity. And this was tested in a group of subjects, 96, divided into 3 groups, 32 in each group. They either received placebo, or they received a low dose of the vaccine or a higher dose of the vaccine. And what we can see in the graphs on the bottom in the severe impairment battery is a decline in dark blue, teal. What we see is a decline in the placebo group that could be rescued with this anti-aging vaccine. So the GEMVAX study is moving forward. This study initially was done in South Korea. This is moving forward as a major U.S. national multi-center study here. And it's an exciting new way to kind of look at dementia and potentially other age-related diseases. There have been some evidence that the same vaccine may help with benign prostatic hypertrophy, reducing the aging of the prostate. So thinking about this, we've got amyloid and exercise and tau and anti-aging, but we know at the heart of many of these degenerative diseases, proteins are folding abnormally, taking on abnormal shapes, which makes them toxic and prevents them from working the way that they normally work. So this is a compound that's been developed. It's very controversial. It's called simufilam, developed by a company named Cassava to correct altered filamin A conformation, normalizing that conformation so that downstream tau and microtubules remain normal, and the toxicity of amyloid does not actually harm cells anymore. So this is fantastic. Now the early results, quite intriguing. We'll take a look at those. But over the last year, you may have heard about the cassava controversy. So in August of 2021, about a year and a half ago, there was a citizens petition filed on behalf of a few investors who were scientists. They accused cassava of manipulating some of the data that they put into scientific papers, perhaps inflating whether or not their drug actually works or not. Now, that was through cassava, really under the lens of the FDA and other regulatory companies saying, hey, wait a minute, have you been falsifying your data? To date, no one has been able to prove any data falsification. Instead, some of the news you've been hearing about suggests that the people who filed the citizen petition were linked to a short sell financial plot. And that's a major issue. And now the Security Exchange Commission is actually investigating those that filed the citizens petition. Reportedly, the short sellers, by causing this up and down in the stock market graph you can see on your right, enabled them to make over $100 million. And so this is big business. And I can't tell you how disgusted I am that we would be manipulating the market. Certainly if cassava did falsify any data, there should be drastic repercussions, but likewise, people trying to manipulate the financial market, potentially leading us to throw out a medicine that may have benefit, is simply unacceptable. So just this past February, 2 months ago, the FDA rejected the citizen petition and said, nope, no evidence. We fully investigated this. This drug moves forward in clinical trials, which are ongoing currently. So we'll see what happens with that cassava controversy. But as of February 2022, this appears over. So let's take a look at that simufilm data. So on the top, the phase 2 data shown here, a placebo-controlled trial of these agents. And what we see is by as early as 4 weeks, we start to see a separation of the groups. With the placebo group showing an improvement, a placebo effect that comes back to baseline by 36 weeks, whereas those treated with the study medication continue to improve out past 36 weeks. So this really seemed to spark the field that this is a very potentially promising agent. Now, just in January, 3.5 months ago, they came out with their phase 2 open label extension. At the end of this study at 36 weeks, they said everybody can be put on the real medicine, and they followed them over time. No placebo group here, but they looked at how do folks do on their memory and thinking testing. What they found is the simufilm group in mild cognitive impairment and Alzheimer's disease had a significant improvement in their memory, as opposed to all of the other anti-amyloid antibodies that we talked about earlier. They slow decline, but they don't stop it. So of all of these drug studies, we see simufilm's results strikingly different. So again, moving forward, thinking about this opportunity, this is a drug that has to be tested in the ongoing phase 3 studies that are underway nationally. So these studies are still recruiting in many areas, including here in Kentucky. We'll see what happens with that simufilm data. Now, we also know that metabolic malfunction is a critical issue. And so the people have talked about Alzheimer's being a disease, a type 3 diabetes, insulin resistance in the brain, and that this leads to the toxicity that we see. We also know that cholesterol is linked through dysregulation of metabolic pathways. The ApoE gene in and of itself, one of the largest genetic risk factors for Alzheimer's, is a cholesterol transporter. So what about metabolic function? Well, there's a lot of excitement in the field over new diabetes medicines. These are called GLP-1 agonists. And you see the commercials on TV all the time, Ozempic, Rybelsus. These drugs have now been used in thousands, tens of thousands, hundreds of thousands. And so the graph on the left is what we call a hazard plot. And what it's looking at is people that were started on a GLP-1 agonist or placebo that were part of the diabetes studies, and then following them over 4.5 years to see how many of those elderly diabetics go on to develop dementia. And what we actually see is by the end of about 4 years, about half of the diabetics that were on placebo progressed to dementia. This is an international epidemiologic observational data. They weren't randomized to placebo. And then we look at the same for the folks that were put on these GLP-1 agonists. And by the end of 4 years, only a little over 20% went on to develop a dementia. This really sparked the field because these GLP-1 agonists are not just being used for diabetes, they're being used for weight loss. And so people have started to really look at this and say, what's going on? Well, we know from some early studies that have been done on the right, this is FDG PET, that is radioactive sugar given to somebody to see how the brain, how metabolically active is the brain. And these are patients with early Alzheimer's disease. And so on the left, the placebo group in red, this is a small number, only about 20 Alzheimer patients, you see the brain powering down. Very few green spots where the brain is using sugar efficiently. And if we treat them with the GLP-1 agonists for just a short 12 weeks, we can turn the brain green, increasing its metabolic activity almost 40% from red negative 20% to green positive 20%. So this is a striking change of correcting the abnormal metabolism in the brains of Alzheimer patients. Now, I will note as well, just like these GLP-1 agonists used for diabetes are also being used for weight loss. The GLP-1 agonists are being investigated through the EVOKE studies, EVOKE Alzheimer's alone, and EVOKE plus Alzheimer's with vascular disease in the brain. And so if we look at this image up top, this brain picture, you see all this white stuff, that is hardening of the arteries, vascular disease in the brain. And we know that that can be as devastating as Alzheimer's disease. So that's what we're looking at currently. There's already very convincing data. Again, one of these hazard plots where we see people in blue that were not on a GLP-1 agonists, their risk for stroke over time. And we can see that that is reduced by 32% if they're given a GLP-1 agonist. So right now, people are starting to think about stroke prevention, not just diabetes, weight loss, and Alzheimer's disease, but vascular disease in the brain being treated by this. And interestingly, also Parkinson's disease, Lewy bodies. In a 12-week clinical trial, 62 patients, we were able to see that people in red that were on the placebo, their Parkinson's disease got worse. This is not memory and thinking. This is how they're moving about in the world. The UPDRS, the Unified Parkinson's Disease Rating Scale. And if we put them on a GLP-1 agonist, they actually got better. So fascinating. And people have thought, well, why and how does this work? And so the brain imaging that we're looking at over here shows us the areas of the brain in yellow that are affected in Alzheimer's or in Parkinson's disease. And normally that yellow turns down the worse your Parkinson's is. And so that's row C on the bottom. All people with untreated Parkinson's on placebo. And what we see in panels B and A are patients with Parkinson's placed on a GLP-1 agonist, turning back on areas of the brain that Parkinson's shut down. So this is an agent. These are a class of agents. There are several of them right now that are out there on the market that may help not just diabetes, but help weight loss, help Alzheimer's, help prevent cerebral vascular disease and stroke, and help prevent Parkinson's disease. Profound effects on brain health. So we think about Lewy bodies, and we know that Lewy body disease is a very common form of dementia. Right after Alzheimer's and vascular disease, probably the most common. What about Lewy body disease? So we've been looking at agents. This is data from what we call the Delphia study. It was a novel phosphodiesterase inhibitor. And what does that really do? So in the bottom graph on the left, you can see phosphodiesterase 9, PDE9. What that does is it allows more cyclic GMP to be around. And cyclic GMP is very, very important for creating memories and keeping nerve cells healthy. So instead of allowing that cyclic GMP to be broken down, it stimulates the health of nerve cells and the ability for them to function. And in clinical trials just reported this year, we see effective dosing over 42 days. We can essentially maximize the cyclic GMP in the brain. And so work on phosphodiesterase inhibitors are moving forward, trying to do what we've seen done with anti-amyloid therapy, come up with a next class. Let's make it better. And so a lot of other candidates out there. It's really been very slow up until the past year or so. There have been very few to no clinical trials or medicines developed for Lewy body disease. And yet in 2022, over the last year, we've seen several come out. So the present study studied 344 people with a medicine called mevidolin, and that is modulates dopamine, a particular receptor, the D1 receptor, important for some of the cognitive benefits in the brain. And this is a drug developed by Lilly. And what we see is a clear improvement in caregiver impressions of how a Lewy body patient is doing. At the higher doses, over 60% of people improved in terms of minimally, and for moderate, over 30% of patients at the highest dose improved moderately on the basis with a beautiful dose response curve. And so mevidolin is moving forward right now into phase 3 studies of Lewy body disease. And hopefully we'll have some unique medicines for Lewy body disease moving forward. Again, it is well known that 30 to 40% of all Alzheimer patients have some degree of Lewy body pathology in their brain as well. So interesting to think that these medicines, while being tested in Lewy body disease, may also provide benefit for some of our patients with mixed Alzheimer Lewy body disease. The ASCEND study was another agent looking at Lewy bodies, 91 patients using neflamapimod. It's a kinase inhibitor that can restore cholinergic function in the brain. So this is just a mouse brain on the left up top, shows how many nerve cells can produce acetylcholine in an animal model of Parkinson's and Lewy body disease. And if we treat them with this medicine, boom, we turn on those nerve cells and get them producing acetylcholine in a big way. So this was just tested, again, came out this year in Nature Communications, looking at about 85 people that were in a placebo-controlled study. And what we find is that the clinical dementia rating scale was positive. Even despite the low number of patients, there was a significant slowing of disease in the Lewy body patients. And physically, their mild Parkinson's symptoms on the timed up and go test, how quick can they get up from a chair, walk across the room and go back and sit in the chair, was significantly improved as well. So cognitive and motor benefits in Lewy body disease, really paving the way towards new medicines. And then ongoing phase 3 studies that are being looked at currently include SHIMMER, funded by the National Institutes on Health. This is an agent that is really looking at this crossover between Alzheimer's and Parkinsonism, Lewy body in the middle. There's a little bit of amyloid. There's a little bit of alpha-synuclein, both toxic proteins. And this medication binds to a sigma-2 receptor, and it prevents either amyloid or alpha-synuclein from exerting toxic effects. And we've seen this in clinical trial data that came out just over a year ago. In the spinal fluid of patients, we see that this medicine, CT1812, improves by reducing A beta oligomers, improves neurogranin synaptotagmin, so is keeping nerve cells healthier at the synapse. And really what's most fascinating is this kind of graph in panel E to the right. The changes in red are different proteins that decrease or increase in Alzheimer's disease. In blue, what we see is the effects when these patients are treated with CT1812, virtually reversing every single change produced by Alzheimer's disease itself. So we're really excited about this medicine moving forward. In Lewy body disease, it's also being moved forward in Alzheimer's disease. And hopefully over the next year or two, we will begin to see the results of this completely new way to treat degenerative dementia. Now, we'll also think about vascular dementia, vascular cognitive impairment, hardening of the arteries. We've been studying this for years now, and we know that as people get older, Alzheimer's goes up until you hit your early 90s, and then your risk for Alzheimer's actually starts going down. And that a lot of this is picked up by cerebrovascular disease in blue. So what have we learned over time? Well, this is data from the Alzheimer's Disease Neuroimaging Initiative, looking at patients in terms of this vascular disease, this hardening of the arteries in the brain. And 55% of those folks, it just progresses, gets worse, and causes dementia as bad or contributes to Alzheimer's dementia. But in 20% of people, they remain stable over time, and 26% of people, their brain actually seems to heal. So, I've thought about this, and well, if these white matter changes, this vascular injury to the brain can heal. That's even better than keeping it from getting worse. We may be able to set back the clock, actually heal people. And right now in Alzheimer's, we're not really trying to heal people as much as just stop the disease. So that really has stimulated the field. And so we've been working here to figure out how we can look at this change in the brain of an individual person. And this is the brain of a person with white matter disease in red. And you can see over time these white matter lesions changing over 1 year. The stable injury to the brain, hardening of the arteries, is in red. The areas that are getting worse are lit up in green, and areas that are healing are in blue. And so for the first time, we can start to look at different medications and how they might heal the brain. So we went back and looked at one of our clinical trials that we did several years ago. This used a cholesterol-lowering medicine called gemfibrozole, which is available in the United States. And we know that people that have been on fibrates have a lower risk for Alzheimer's. So we were testing it in Alzheimer's disease. But at the end of the day, we saw to the far left that white matter hyperintensities, this hardening of the arteries, was slowed in terms of its progression with the fibrate therapy. But that was not statistically significant. It was intriguing. We wanted to look at, well, how do fibrates actually do that? And so people that were on fibrates had increased growth of their white matter hyperintensities. And we said, well, that can't be it. And then we looked at regression, the healing properties. And this was almost statistically significant, suggesting that the fibrates are actually working to heal the brain. We couldn't explain why the people treated with fibrates were still getting worse, but when we looked more carefully, we found an imbalance. There were more people in this group with high blood pressure, and the association of the white matter hyperintensity growth was with the blood pressure, not the treatment effect. So this really raises some interesting questions. How does gemfibrozole do this? Is it because it's also lowering Alzheimer's disease? Is it because it reduces neuroinflammation? Is it because it improves blood flow to the brain? Is it because it improves metabolic function, cholesterol, triglycerides, glucose, and other inflammatory cells? We really don't know yet, but this is a medicine that looks like it directly heals vascular disease in the brain. Vascular disease is very, very common. Here in Kentucky, it's as common as Alzheimer's disease as a cause for dementia. So we're also working on other studies. This is an agent, ADV, also known as CY6463, that functions, right, to target both Alzheimer's and vascular pathology in that overlap. Again, working through this CGMP. We saw that before with the Lewy body disease medications. So similar pathways here to improve neuronal health. So this study is in phase 3 right now, close to enrollment, but hopefully in the next year we'll get a readout. I also wanted to talk a little bit about late disease. What is it? Many people don't understand this disease that are not dementia experts. But the brain tissue you see in the upper left is a normal control, lots of purple here. And in some folks with Alzheimer's, we see the hippocampus, the memory areas of the brain shrink. This is severe shrinkage, and it's not caused by Alzheimer's. It's caused by a mimic of Alzheimer's. People in their 80s and 90s have a disease often that's called late. And by the time you reach your 90s, late actually can start to become more common than even Alzheimer's itself. As Alzheimer's is coming down, late is skyrocketing. So a major cause. So late stands for limbic associated TDP-43 encephalopathy, which is a mouthful. We call it late because it affects people late in life. So about 2 years ago now, there was a consensus meeting held by the NIH to name the disease and establish its importance, to try to find biomarkers. And here at UK, we're doing the first ever clinical trial in the world targeting this TDP-43 late syndrome. It really comes through discoveries that the genetics of this disease are linked to a potassium channel that we can modulate with a drug called nicorandil to help the brain. Now, nicorandil is not available in the United States, but it is used in several other countries in the world for heart disease. What we know about it is nicorandil prevents death. So we look at these folks, they all had cardiovascular disease. We look at these folks that were not on nicorandil, and we look at their population, about 5%, 6% or so died by the end of 3 years. Whereas if they were on nicorandil, which is used for chest pain, it improves blood flow to the heart, the likelihood of death was cut almost in half. That is pretty darn impressive. Now we look at the brain and we say, well, you know, it improves blood flow. How's it working to prevent damage to the memory areas? Well, this potassium channel actually exists in the hippocampus. And if we look at an area that has hippocampal sclerosis late, we see this potassium channel lining all of these little blood vessels. If we look in a different area of the brain that does not have late pathology, we see very low background staining for the potassium channel. So this potassium channel is upregulated in these areas. If we of a damage, if we turn it on, blood flow is restored. And so the NIH is holding another consensus meeting in another month at the end of May that I am a part of with a small handful, 24 or so folks from around the world, to put together the clinical criteria for late. And so this study is unrolling right now. We've been able to bring this drug into the country with FDA approval. We're enrolling it right now in what we call the SMART HS study, people over the age of 75 with memory problems that do not appear due to Alzheimer's disease are likely due to late. And we're trying to give them this medicine and treat their dementia. So why do we have to have other targets other than amyloid? Well, I think we've kind of made that argument already with these different disease states that are overlapping. So if we look at these graphs, we can see to the left, dementia now, and on the right, dementia in the future. And we've already talked about slowing A beta by 30%. Well, how about if we also take tau out of the picture? How about if we also eliminate aging effects on the brain? Metabolic dysfunction, we correct that. We exercise, we socially engage, we fix toxic protein shapes, we correct Lewy body disease, we treat cerebrovascular disease and TDP-43 late. Dementia in the future could disappear. So that would be wonderful. I'd hate to be out of a job, but for our children and our children's children, this is worth it. We're not going to do it with amyloid alone. So I am going to move on and just talk about a few other things. What about symptomatic treatments? And this is about behavioral psychiatric symptoms of dementia. What's new out there? Everybody knows, you know, well, we can use antidepressants and maybe we can throw an antipsychotic at somebody, but there are risks and we get in trouble. What do we do? And yet we know these behavioral problems are major factors limiting quality of life. So what do we know about antipsychotics? Well, we know that they have a black box warning. This is dementia patients. And if we look at risk for stroke, heart attack, death, approximately 2.6 in the placebo population. That increases to 4.5 if we put somebody on an atypical antipsychotic. So about a 2% increase risk. So we really do need to be cautious about using these medicines. And that's really pushed the field to say, what else do we have? Well, newer medications, newer antipsychotics have been developed. Pimavanserin, and this is data that came out New England Journal of Medicine in 2021, that pimavanserin appears as safe as placebo in the clinical trial. It still does carry the FDA black box warning as part of the class of antipsychotic therapy, even though we've not seen that kind of risk in any of the clinical trials of pimavanserin. What we do see is that the likelihood of people relapsing with psychosis on pimavanserin is dramatically reduced. It's only about 35% what it would be for folks on placebo. So we could treat 2 out of every 3 dementia patients with psychosis. This study was so statistically significant that it had to be stopped early because there was no sense continuing. We already proved the point. But it'd be nice not to have an antipsychotic. What else is out there? Well, this is an agent, masupridine, which is not an antipsychotic. It's an antagonist of the 5-HT6 serotonin receptor. And this is a clinical trial data that's come out just recently showing, in effect, the placebo group, their psychosis getting worse over time, climbing steadily in green, and with masupridine, what we see is a reduction that reached statistical significance by 26 weeks. So we have benefits in agitation, aggression, psychosis, and phase 3 trials are currently underway. So the last study I'll talk about is end-stage dementia. So this is a patient, we all recognize her, 82 years old, no longer walks, talks, or engages in the world around her. She moans and grimaces like she's in pain, and we really want to keep her comfortable. So what else can we do besides dosing heavily with opiates and benzodiazepines? Well, cannabinoids may be the answer. CBD oil, THC can have profound effects on calming and comforting individuals. And so the NIH has funded Libby study starting just this year. 12-week trial for hospice-eligible patients where we're going to give them THC and or CBD to see if we can help. So why do folks want to participate in research? Why should they? Maybe they should just go get lecanemab. Well, many people say, I don't want to participate in a clinical trial. They're not going to work. Well, we know that they're going to work eventually. Well, I could get the placebo and then it's a waste of time. Yes, that's true. It could make things worse. And my answer is the medicines are based on state-of-the-art science. We wouldn't move them forward if we didn't think they were going to work. Even in the placebo arm, there are benefits of enhanced care and patients always do better. And we always watch safety. So this is a chart from a paper years ago. It shows a 12-year trajectory for patients with Alzheimer's and or Alzheimer's with Lewy body disease, and the black lines at the bottom. In blue, heading out to that blue star, is my patient X. He's been receiving lecanemab for 10 years now. Look where his mini mental is. He participated in a trial for himself. He did it for his children. Where would he be if he had waited for drug approval? Maybe it's just a fluke, but watching these patients who have participated in a clinical trial, received an experimental medicine that we now know is proven to slow the disease by 27 to 40% is amazing. So still lots of room for other experimental therapies, lifestyle modifications, and we need to continue moving forward with these medicines. So I'm going to pause there. Really today, what has been a whirlwind tour of not just amyloid therapies, but also non-amyloid therapies targeting every target we have. So with that, I've stopped sharing my screen. I can certainly see the chat. And so we do have one question. Do you believe the ApoE4 genetic test is helpful for people who have had both parents with dementia? This is a great question, Rita. Currently, we don't routinely test genetics unless there's a family risk of autosomal dominant disease. That's the kind of Alzheimer's that hits people in their 40s and 50s. But with what we've learned about the anti-amyloid therapies, the risk for ARIA being dependent on ApoE, the recommendations are, at least for people that are potentially going to be put on lecanemab, that we indeed should check their ApoE genetics so that we can have a heightened surveillance for those that carry 1 or 2 copies of E4. I do think one needs to be cautious about testing these genetics in somebody. 1 out of 6 people walking down the street have an ApoE4, and they will never get Alzheimer's disease. Conversely, 60% of the patients with Alzheimer's do not have an ApoE4. So it's not a definite one way or the other, but in your medical record, it could potentially lead to genetic discrimination. Now, for our folks with full-blown MCI or Alzheimer's and documented amyloid in the brain, yes, the cat's already out of the bag. We do need to get the ApoE, and that may change further in the future, Rita, if its clinical importance and meaning becomes more relevant with the new drugs that are being developed. So fascinating, fascinating question. I think we're at the end of our time. If no one else has any other questions today, we'll end and move on to some of our other programming. I'm delighted that y'all came and learned a little bit about what's happening in the field. We need to do better. We are doing better. We are going to move forward. We're going to take that 30% gain from removing amyloid, and we're going to turn that into 100%. It's only a matter of time, and we're working towards that goal. We're going to do it through many of these medicines as well as lifestyle modifications. Thanks, everyone. Have a great day.
Thank you. And just a reminder for all of the participants, if you complete the evaluation that was emailed to you earlier, then you can be eligible for continuing education credits.